Pancreas, congenital anomalies, annular pancreas, definition, a ring of pancreatic tissue which surrounds the second part of the duodenum, leading to duodenal obstruction, type of the patient, during the first year of life, half of the cases, symptoms, vomiting, main symptom, signs, jaundice may be present, investigations, contrast radiological studies, treatment, duodenojejunectomy. Pancreatitis, acute pancreatitis, mortality is about 10%, etiology, bile duct stones 50%, excess alcohol intake 35%, trauma, idiopathic, rare causes. Bile duct stones, a stone lodged in the extreme lower part of the common bile duct is likely to obstruct the pancreatic duct as well. A stone in the ampulla of Vater leads to regurgitation of the bile into the pancreatic duct, leading to activation of the pancreatic enzymes. Now it's realized that passage of a stone through the ampulla may initiate an attack. Excess alcohol intake, trauma, may be accidental, operative, ERCP, the third most common cause of pancreatitis, idiopathic in 20% of cases, and rare causes including viral infection, mumps, hyperparathyroidism, corticosteroids, and hypertriglyceridemia. Pathology, pathogenesis, premature activation of pancreatic digestive enzymes while they are still in the pancreas, leading to autodigestion of the gland. The exact mechanism of enzyme activation is not understood. Inflammatory cytokines are produced and trigger an inflammatory cascade, leading to systemic inflammatory response syndrome. The condition is like a major burn to the peritoneum, which produces abundant protein-rich exudate. The enzyme lipase, which is released from the pancreas, splits fat in the omentum and peritoneum, producing glycerol and fatty acids. Acids binds with calcium, leading to insoluble calcium salt, which manifests as white spots of fat necrosis. The proteolytic activity of the liberated pancreatic enzymes produces vasoactive kinins and other chemical mediators, leading to hemodynamic and respiratory consequences. Gross picture, the severity of pancreatic inflammation ranges from mild edema to hemorrhage, leading to hemorrhagic ascites, hemorrhagic pancreatitis, and severe necrosis or necrotizing pancreatitis. White spots of fat in the peritoneum. Complications, systemic and local pancreatic pseudocyst and pancreatic abscess in 4 to 5% of the cases, systemic complications in the form of multiple system failure, shock from losing plasma into the peritoneum and retroperitoneal, losing blood in hemorrhagic cases, adult respiratory distress syndrome, respiratory failure, renal failure followed by prolonged hypovolemia, consumption coagulopathy, paralytic ileus and acute gastroduodenal ulcer, and hemorrhage, tetany, may occur because of hypocalcemia. Some patients suffer from relapsing acute pancreatitis, enjoying relatively normal health between attacks. Binding of acids with calcium is likely to produce hypocalcemia in severe cases. The occurrence of any of the system failures worsens prognosis, and if improperly treated, one system failure leads to another, leading to death. Pancreatitis begins when digestive enzymes become active inside the pancreas and start digesting it. Symptoms of acute pancreatitis include severe acute pain in upper abdomen, nausea and vomiting, shock commonly present with moderate tenderness and rigidity, clinical picture in general, symptoms, upper abdominal pain, the main symptom in all cases, pain characterized by acute onset, gradual increase in severity and becomes agonizing, commonly radiating to the back, may follow heavy meal or ingestion of alcohol, vomiting and retching are often present. Signs, general signs, fever and tachycardia are common, hypovolemic shock in severe cases. The patient commonly sits leaning forward as this position partially relieves the pain. A tinge of jaundice is sometimes observed. Local signs, less than expected from the severity of pain, only mild tenderness and rigidity, and this is explained by the position of pancreas being retroperitoneal organ, so it's far from the sensitive parietal peritoneum. Blood-tinged exudate leak from the retroperitoneal space, leading to bruising around the umbilicus, Coulin signs, and in the loin, Gray-Turner sign, late manifestations. 2 to 3 weeks after the acute episode, upper abdominal swelling is sometimes observed, and this is called pancreatic pseudocyst. Investigations for lab, serum amylase, urinary amylase, serum lipase, arterial blood gases, biochemical changes, CBC, imaging, plain X-ray of the abdomen, abdominal ultrasound, CT scan with IV contrast, MRCP, ECG, and the cardiac enzyme creatinine phosphokinase CPK. For the laboratory, Serum amylase is usually elevated within few hours to levels equals to or more than 1000 international units per deciliter. Normal value is from 100 to 300. It remains elevated for 2 to 3 days. The problem with serum amylase is that it's not specific for acute pancreatitis. It's elevated in other conditions as perforated peptic ulcer, acute cholecystitis, intestinal obstruction, and acute mesenteric ischemia. Enzyme level in these cases don't exceed 500 international units per deciliter. Urinary amylase, used for diagnosis of patients who present after 2 days of the start of the pain, as the serum amylase is cleared out by the kidney. Serum lipase. Lipase has slightly longer half-life, particularly useful in cases of delayed presentation. Elevated lipase levels are more specific than amylase levels. Arterial blood gases, to detect cases who will need mechanical ventilation. Biochemical changes, mild bilirubin elevation, hypocalcemia, hyperglycemia, hypoproteinemia, and elevated blood urea. CBC showing leukocytosis. Hematocrit is usually elevated as well because of fluid loss and lowered in hemorrhagic pancreatitis. Imaging, plain X-ray of the abdomen showing dilated short segment of the small intestine, which is commonly referred as sentinel loop. There may be also distension of the transverse colon and collapse of the descending colon, colon cut off sign. Abdominal ultrasound showing gallbladder stones. Stones impacted in the lower end of the common bile duct are usually not seen, yet their presence is indicated by dilatation of the biliary tree. CT scan with IV contrast, very helpful in diagnosis, revealing enlargement of the pancreas, peripancreatic edema, and intraperitoneal fluid. Most important is its ability to detect pancreatic necrosis, which is diagnosed when a big part of the parenchyma is not enhanced after contrast injection. The presence of necrosis means severe attack. CT scan should be performed and at least 48 hours after the onset of symptoms to detect the extent of necrosis. Magnetic resonance cholangiopancreatography (MRCP) may be done if cholelithiasis is suspected. ECG and CPK are done to exclude myocardial infarction. Assessment of severity, Ranson scoring system to assess severity and prognosis. On admission, we have age, white cell count, blood glucose, serum LDH, and AST. For initial 48 hours, hematocrit decrease, bone elevation, serum calcium, arterial oxygen, and base deficit. For admission, the age more than 55 years, white cell count more than 16,000 per microliter, blood glucose more than 200 milligrams per deciliter, serum LDH more than 350 international unit per liter, AST more than 250 international unit per liter, base deficit more than 4 milliequilibrium per liter, arterial oxygen less than 60 mm mercury, serum calcium less than 8 mg per deciliter, bone elevation more than 5 mg per deciliter, and hematocrit decrease more than 10%. Patients with severe pancreatitis who should be treated in the ICU unit. Differential diagnosis from other causes of acute upper abdominal pain, perforated peptic ulcer, acute cholecystitis and biliary colic, acute mesenteric vascular occlusion, leaking aortic aneurysm, acute myocardial infarction. All these causes of acute upper abdominal pain are serious, and if neglected, they may be fatal. The diagnosis of acute pancreatitis is mainly done by exclusion of other causes of acute upper abdominal pain. Treatment, conservative treatment is the best, aimed to support different body systems, easily remembered as the R regimen, relieving pain by pethidine or mipridine. This is combined with an atropine derivative to counteract the spasm of sphincter of Uddi induced by opiates. Replacement of lost fluids by crystalloids and plasma. Blood is used in hemorrhagic cases. It's monitored by vital signs, urine output, central venous pressure, and hematocrit value. Calcium is added to the infusions as required. Respiratory support by oxygen mask or by mechanical ventilation in respiratory failure. Rest of the pancreas and bowel by keeping the patient MPO, no oral intake. IV fluids are given for a few days until vomiting and nausea stop. Nasogastric tube suction is sometimes needed. Severe prolonged cases require total parenteral nutrition. Resistance of infection by prophylactic antibiotics. The value of antibiotics is controversial, yet it may reduce the incidence of infection in cases of necrotizing pancreatitis. The preferred antibiotics are those of carbamazepine class, impenem, cilastatin, or meropenem. Removal of an obstructing bile duct stone by ERCP and sphincterotomy in acute attack is recommended if there is obstructive jaundice or cholangitis. Otherwise, this intervention is not recommended during the attack. Reassessment when symptoms completely resolved by ERCP. In biliary pancreatitis, cholecystectomy and removal of common bile duct stones, if not endoscopically removed, is performed within the same hospital admission. Alcoholic patients are advised to give up alcohol intake. Surgical treatment indicated for severe necrotizing pancreatitis as detected by CT scan. Necrotic tissue is excised and tube drains are left in the peritoneal cavity to allow post-operative lavage. Drainage of pancreatic abscess drained externally by a tube. Persistent pseudocyst, which doesn't resolve in 6 weeks, internally drained to the stomach or to jejunal loop. Chronic pancreatitis incidence, rare in Egypt. Etiology, overconsumption of alcohol, this is the main cause. Stone in the lower end of common bile duct, second common cause. Pathology, there is one or multiple strictures of the pancreatic duct, irreversible replacement of the acinar cells with fibrous tissue, gradual loss of both exocrine and endocrine functions. In a few cases, inflammation and fibrosis of the head of pancreas obstruct lower part of the common bile duct, leading to obstructive jaundice. Clinical picture, epigastric pain radiating to the back. It may be mild or severe and continuous or interrupted, commonly causing drug addiction for analgesics. Malabsorption from loss of enzymes, producing steatorrhea in a third of the cases with loss of weight and weakness. Stools typically are soft, greasy, and foul-smelling. Diabetes mellitus developing in extensive pancreatic damage. It occurs in a third of the patients. Few physical signs, malnutrition and tinge of jaundice in 3% of cases. There is epigastric tenderness. Investigations, lab. No laboratory test is specific for chronic pancreatitis. Steatorrhea assessed by measuring fecal fat excretion. Lung test, secretin and pancreozymin stimulation showing reduced pancreatic secretion. Glucose tolerance test. Serum bilirubin and other liver function tests. Imaging, plain X-ray showing calcification or stones, ultrasound and CT scan to detect pancreatic enlargement and showing associated biliary pathology. Endoscopic retrograde cholangiopancreatography (ERCP) is of great value, performed if operation is considered. The architecture of pancreatic duct is revealed. Common features include strictures, stones, cysts, alternating strictures and dilatations of the pancreatic duct, which give appearance known as the chain of lakes. Pure pancreatic juice can be obtained for cytology to exclude malignancy. MRCP, providing information on pancreatic ductal system, relatively safe, reasonably accurate, non-invasive, fast, and very useful in planning surgical or endoscopic intervention. Endoscopic ultrasonography, this is the best modality of imaging for pancreas, requiring highly skilled gastroenterologist. The most predictive feature is the presence of stones. Treatment, abstinence from alcohol intake is essential. Conservative treatment for majority of cases, controlling diabetes by insulin, correction of malabsorption by intake of pancreatic enzyme tablets with meals, low-fat diet with oral supplementation of fat-soluble vitamins, controlling pain by non-opiate analgesics to avoid addiction. Surgery, indicated for persistent uncontrolled pain. Options, resection of part of the pancreas is done when it's severely damaged and the rest of the organ is relatively healthy. Drainage of dilated pancreatic duct by pancreaticojejunostomy. Celiac block, interrupting the pain pathways from pancreas and relieving pain from chronic pancreatitis. Therapeutic value of ERCP, endoscopic division of sphincter of Oddi, sphincterotomy, is done in cases of obstruction of the duct opening with stone and with stenosis of duodenal papilla. Pancreatic pseudocyst, pathology, nature, collection of pancreatic secretion and inflammatory exudate with lining of inflammatory tissue rather than epithelium. So it's not a true cyst, it's a false cyst. Etiology, develops in 10% of acute pancreatitis, usually after 2 to 3 weeks, or chronic hepatitis or pancreatic trauma. Site, lesser sac between pancreas and stomach. Complications, infection, hemorrhage and rupture. Clinical picture, small pseudocyst is painless, may be discovered by follow-up ultrasonography. Large cyst causes discomfort, manifests as upper abdominal swelling which may reach size of a melon. Investigations, CT scan is most accurate. Endoscopic ultrasound and aspiration of fluid, revealing high level of amylase. Treatment, most of these cysts resolve spontaneously. Clinical and ultrasound follow-up is needed. Persistent pseudocyst for 6 weeks, surgically drained, waiting for 6 weeks to allow development of a strong cyst wall, which can hold sutures. The cyst is internally drained to the stomach. cystogastrostomy, or to the jejunal loop, cystojejunostomy, is done by making incision in the anterior abdominal wall of the stomach, then incision of the posterior gastric wall and the cyst wall, which are adherent to each other. Continuous interlocking sutures bind the posterior gastric wall to the cyst wall, securing homeostasis and making an opening between the cyst and the stomach, so the cyst gradually disappears. Endoscopic drainage of the cyst to the stomach is feasible in presence of resources and experience. Pancreatic neoplasms, exocrine and endocrine. Exocrine, benign adenoma, malignant adenocarcinoma. Endocrine, they are rare, from alpha cells, glaucogonoma, beta cells, insulinoma, delta cells, somatostatinoma. Pancreatic adenocarcinoma, pathology, gross picture, infiltrating, hard, irregular, site in the head, 60%, and body and tail, 40%. In the head, 2/3 of the head proper, and 1/3 periampullary, ampulla of Vater, duodenal papilla, or lower end of common bile duct. Microscopic picture, adenocarcinoma arising from the ductal system. Cyst adenocarcinoma is rare. Spread, direct to the common bile duct, infiltrated early in pancreatic head cancer, leading to obstructive jaundice. Duodenum, portal vein, inferior vena cava. Lymphatic to adjacent lymph nodes and to the nodes of the portohepatis. Blood spread to the liver mainly. Transperitoneal, peritoneal seeding, and ascites. Incidence between the age of 55 and 70 years, affecting males more than females. Prognosis is poor. 5-year survival rate is about 5%. Etiology, the exact etiology is unknown. Factors which increase the risk: smoking, obesity, chronic pancreatitis, and diabetes. Endocrine neoplasms, which arise from APUD cells, APUD cells, are termed apodomas. They are interesting in regard to their metabolic consequences and the possibility of associated APUD neoplasms in other organs, which are known as multiple endocrine neoplasia, MEN syndrome. Differential diagnosis of the pancreatic adenocarcinoma: calcular obstructive jaundice, chronic pancreatitis, and other causes of jaundice such as viral hepatitis. Clinical picture for the carcinoma of the head: obstructive jaundice and pruritus, painless jaundice, sometimes painful, progressive, may be temporary if an obstructing periampullary carcinoma sloughs, deep olive green, pruritus. The liver is enlarged because it's engorged with bile. The gallbladder is distended in half of the cases. Anorexia and loss of weight are marked. Carcinoma of the body and tail manifest late. The manifestations are nonspecific, including anorexia, loss of weight, and weakness. Epigastric pain radiating to the back, this is a late symptom. Migrating inflammation of the superficial veins. Thrombophlebitis migrans accompany visceral malignancies. The liver may be enlarged from metastasis and ascites. Then we have a comparison between calcular obstructive jaundice and malignant obstructive jaundice. For calcular obstructive jaundice, peak age incidence, middle-aged, gender, more in females, duration of jaundice long, course intermittent, depth moderate, abdominal pain, colicky, more in epigastrium and right hypochondrium, anorexia and weight loss absent, fever may be present, gallbladder usually impalpable, obeying Courvoisier's law, ultrasound usually fibrosed gallbladder with stones, CT scan, gallstones, ERCP, stone in the common bile duct. Malignant obstructive jaundice, peak age incidence, elderly, gender, more in males, duration of jaundice, short, course, progressive, depth may be very deep, abdominal pain may be absent, dull aching and referred to the back, anorexia and weight loss marked, fever absent, gallbladder commonly palpable, ultrasound, marked distended, thin-walled gallbladder, CT scan, head neoplasm is usually seen, and ERCP abrupt termination or failure of cannulation of the common bile duct. Investigations, liver function tests, and tumor markers. Liver function tests: bilirubin elevated, mainly the direct bilirubin, high alkaline phosphatase, prothrombin concentration is low from defective absorption of vitamin K due to lacking of bile salts in the intestine. Tumor markers: CA19/9, useful method for confirmation and in follow-up treatment. Carcinoembryonic antigen, CEA. CEA is a tumor marker for GIT carcinomas in general. It's elevated only in 40 to 50% of patients with pancreatic cancer. Biopsy is not needed if clinical evidence, elevated CA19/9, and hypodense lesion on triphasic CT are all present. When CT appearance is atypical, needle biopsy is considered. Positive cytology justifies resection of operable cases. On the other hand, a negative result cannot rule out malignancy. Imaging, abdominal ultrasound. This is the first imaging done when obstructive jaundice is suspected. It may fail to show pancreatic carcinoma because of the overlying colonic gases. The examination is useful to detect the cause as extrahepatic obstructive jaundice, showing dilated extra and intrahepatic bile ducts, sometimes finding gallstones. This is the cause of obstruction. Liver metastases are readily diagnosed by ultrasound. Endoscopic ultrasound showing relation of the tumor to the blood vessels and allowing taking a biopsy. CT scan ideally should be triphasic, spiral CT within thin cuts, 3 mm, showing tumor, its local extent, liver metastasis. The tumor classically appears as hypodense lesion. It's important to look for invasion of superior mesenteric vessels and portal vein. It allows starting percutaneous fine needle aspiration cytology of the lesion. Endoscopic retrograde cholangiopancreatography, ERCP or PTC, exact delineation of the site of obstruction, differentiate malignant from stone obstruction of the bile duct, placing a stent in the bile duct to allow drainage of the bile and relieve jaundice either by preparation for surgery or permanently in very ill inoperable cases. Treatment, patients who are unfit for surgery. Patients who are fit for surgery, we have different options. Those who are unfit for surgery, jaundice can be treated by endoscopic stent passed from the duodenum into the common bile duct, then past the block to dilated area above to drain the bile into the duodenum. Self-expanding metal stents are better than plastic stents. Patients who are fit for surgery, surgery is the best modality for treatment. Possible risks of surgery on obstructive jaundice patients: renal and hepatic failure consequence upon the septicemia, septicemia caused by bacteria migrating from the bowel to the bloodstream, excessive hemorrhage resulting from hypoprothrombonemia due to lack of absorption of vitamin K. Preoperative preparation to avoid mentioned risks: parenteral vitamin K administration at a dosage of 10 mg IV bed. Oral vitamin K is not absorbed. Administration of oral bile salts for 2 days before surgery to prevent migration of bacteria to the bloodstream. Prophylactic and parenteral antibiotics against gram-negative bacilli and given before and continued during and after the operation. The patient is kept adequately hydrated. If the bilirubin is above 15 mg per deciliter, give mannitol before, during, and after surgery. This is an osmotic diuretic which is administered intravenously and helping reducing incidence of renal failure. Sugar-rich food which helps rival build up glycogen to stand the stress. Operations. For operable cases, 10 to 15% of cases, we do pancreaticoduodenectomy or Whipple operation. The following structures are removed: head and neck of pancreas, whole duodenum as it shares the same blood supply as the head of pancreas, antrum of the stomach, gallbladder, and the common bile duct. The operation ends by performing the following anastomosis: hepatic duct to the jejunum, pancreatic duct to the jejunum or stomach, stomach to the jejunum. Mortality rate of operation approaches about 10%. The 5-year survival after resection is poor, but it's better with periampullary carcinoma 30% than carcinoma of the head proper, which is from 0 to 5%. Operable potentially curable represents 10 to 15% are those who have neither liver nor peritoneal deposits. They are not fixed to the hepatic or celiac artery. Those cases deserve to perform Whipple operation. Adjuvant chemotherapy and or radiotherapy may be given after resectional surgery or before operation neoadjuvant therapy. In inoperable cases that are either liver or peritoneal metastasis or involvement of celiac lymph nodes or invasion of the superior mesenteric artery, superior mesenteric vein, portal vein, or tumor more than 5 cm, so it becomes palpable. For inoperable, incurable cases, majority of cases, drainage of bile to the intestine by hepaticojejunostomy or cholecystojejunostomy to avoid the risk for future duodenal obstruction by growing tumor. Some surgeons routinely add gastrojejunostomy. Insulinoma pathology, origin, a tumor in the beta cells of islets of Langerhans, usually benign, few cases are malignant. Site, commonly found in the body and tail, rarely multicentric. Some insulinomas are part of MEN syndrome, MEN type 1, with associated anterior pituitary adenomas and parathyroid hyperplasia. The specific feature is the secretion of excess insulin irrespective of the blood glucose level. This leads to hypoglycemia. Intraoperative ultrasound is very useful in localization of the tumor. Clinical picture, type of the patient, adult under 40 years, usually overweight due to overeating, bizarre behavior, unconscious episodes, Some patients are misdiagnosed as having psychiatric illness, palpitation, nervousness, other symptoms of sympathetic hyperactivity, Whipple's triad, symptoms of hypoglycemia, sweating, anxiety, tremor, confusion, and coma that are precipitated by fasting or exercise. During the attack, blood glucose level is less than 45 mg per deciliter. Symptoms are relieved by glucose. Investigations, lab, low blood glucose level, high insulin level in the blood, imaging, localizing tumor by endoscopic ultrasound and CT scan. Treatment, the part of the pancreas which contains the tumor is resected. Gastrinoma or Zollinger-Ellison syndrome. Pathology, rare tumor in incidence, origin, non-beta islet cells secreting excess gastrin hormone, may be component of multiple endocrine neoplasia, MIN type 1, hypergastrinemia resulting in excessive hydrochloric acid secretion and consequent intractable peptic ulceration. Most gastrinomas are found in the gastrinoma triangle. Clinical picture, abdominal pain caused by peptic ulceration which may bleed or perforate. Diagnosis of Zollinger-Ellison syndrome suspected when we meet the following: ulcers resistant to treatment to H2 receptor antagonists, recurrent ulcers, multiple ulcers, and ulcers in unusual sites as distal duodenum and proximal jejunum, peptic ulcers at extremities of age, diarrhea present in third of the cases. In contrast to insulinoma, 60% of gastrinomas are malignant. Intraoperative ultrasound is very useful in localization. Investigations, we have upper GI endoscopy, barium meal examination showing the ulcers, radioimmunoassay estimation of serum gastrin. The normal level is below 150 nanograms per liter. Most cases show levels above 500 nanograms per liter. Some patients have intermediate levels between 200 and 500 nanograms per liter. Such cases show doubling of the serum levels when stimulated with IV calcium or secretine. Localization of the tumor by CT scan, endoscopic ultrasound, and octreotide scintigraphy. Treatment. Ideal treatment is to excise the part of the pancreas containing the tumor. Only 20% of tumors are suitable for resection because of the multiplicity and poor localization. Commonly, tumor resection is not possible and total gastrectomy is done to completely abolish acid secretion. A less effective alternative is prolonged intensive therapy with proton pump inhibitors. Then we have an additional something called WADHA or WADHA, WDHA, Vipoma or Werner Morrison, 80% malignant in the body and tail of pancreas, characterized by achlorhydria, hypokalemia, endocrine tumor secreting VIP, and watery diarrhea. Investigations are PET-CT, and this concludes the pancreas.